I would request Colonel Parashar to kindly stay on to the dais as he is the last chairman of the last session of the 7th World Congress on Clinical Preventive Cardiology and Imaging. He'll be joined by the organizing chairman, Dr. Chopra. We'll have 3 speakers all deliberating back to back for 10 minutes. This segment is a symposium on clinical and preventive pediatric cardiology, and we'll take the last couple of minutes for discussion. May I request the Chairman Scientific Committee, Colonel Parashar, to invite Dr. Sonia L. Saiedi and set the ball rolling. Over to you.
It is a pleasure and a rare opportunity to preside a session containing only the ladies. So that is a good thing.
That was the intention, so that people can stay on for a longer time.
And as I understand that it will be a very, very interesting session again, because the topic is very different. So, and without wasting much time, as you know, many of you have to go or something. So the topic is a clinical and preventive pediatric cardiology. Very interesting subject. So the first talk will be given by Sonia from Egypt, the myocardial dysfunction in systemic diseases. So the time is 10 minutes with a, you can start the stage. You should always start the timing when the person comes on the stage and start talking. Not that when he or she is sitting there. So now is the correct time. In future also please keep in mind.
I have to thank the organizing committee, Dr. Chopra, for inviting me to share with you the World Congress of Clinical and Preventive and Imaging Cardiology. It's a privilege, and we hope to invite you to make your 8th or 9th conference in Egypt. I know that we are in the last sessions, last speakers, and we're talking to adult cardiologists about pediatric cardiology, so we'll try to be simple and straight to the point. I was confused, what should I talk about and what should I cover in 10 minutes? Because everything in pediatrics, I can talk about the whole Nelson textbook of pediatrics, that every single disease involves the heart. Renal disorders, blood disorders, liver, diabetes, hypertension, hyperlipidemia, chronic lung disease, and malignancies. So let's take it quickly. And I wish to present this as an interactive way so that the audience would not be sleepy at the end of the day, but we'll try. What's the risk factors that cause cardiac affection in renal disease, which is common in Egypt? Chronic renal failure is a real problem in Egypt. So what are the risk factors that make these patients come to us? Hemodynamic overload, anemia, causing heart failure, calcium phosphate metabolism disorders, electrolyte imbalances, and factors related to dialytic procedures. And the mechanism includes the traditional, like endothelial dysfunction, like arterial stiffness, like calcification. These occur in the general population, okay? And they cause atherosclerosis, arteriosclerosis, ischemic heart disease that would end in arrhythmias and death. On the other side, because of hypertension and eccentric LV hypertrophy, there is maladaptive cardiomyopathy, diastolic, then systolic LV dysfunction, cardiac failure and arrhythmias ending in death. So, what are the complications of a chronic renal failure that we should look for as pediatric cardiologists? We would look for hypertension, anemia, calcium phosphate disorders, cardiomyopathies, of course, heart failure, arrhythmia, sudden cardiac death is common in those patients, and of course pericarditis and pericardial effusion is common. So what is the role of pediatric cardiologists in chronic renal failure to detect early involvement of the heart. We would detect them by diastolic dysfunction before we get to the point of systolic dysfunction and actual cardiomyopathy. We can, whenever we find LV hypertrophy, we treat the hypertension promptly and treat the anemia, and we would not let them reach the final ending. When we talk about liver manifestations of heart disease, but there are heart manifestations of liver disease. So the liver and the heart interact. And in cardiac disorders, like standard and surgical treatments of congenital heart disease, heart failure, pericardial disease, these are often complicated in a child with liver problems, and this includes post-open heart and acute liver failure. Drug-induced liver injury that can even occur with the simplest drug in the pediatric age group, like paracetamol given for fever. The Fontaine operation, which has become very often a commonly used procedure for the pediatric single ventricle repair, has far-reaching effects on the liver, well-known effects, liver congestion, liver fibrosis, and in some cases liver failure that can resurface years after the operation. So you adult cardiologists are going to treat this. And the lasting effect that the hepatologist should know is the heart transplant patient. The effect of liver disease on the heart is the hyperdynamic circulation, acute variceal hemorrhage, and ascites. They all affect the heart. So this is the interaction. The liver and heart are together. What other disease involve both? Both are involved in glycogen storage disease. And is there a way to prevent heart dysfunction in those diseases? Yes. Begin enzymatic replacement early. Yes. Iron storage disease to be treated early. Chronic hemolytic anemias we'll discuss later, allergen syndrome, and extrahepatic biliary atresia. So, I have attended the diabetes sessions that the adult cardiologists presented. We also see those patients in pediatric age group. The heart is involved in the macrovascular complications. There's also microvascular complications. The heart causes stroke, peripheral vascular disease, and foot problems are all macrovascular complications. Microvascular complications include the retinopathy, the nephropathy, and the neuropathy. So, what are the complications of chronic hyperglycemia that involves the heart? Can't get this mouse to work. Well, atherosclerosis, endothelial dysfunction, hypertension, dyslipidemias, procoagulant state, antifibrinolytic state, and vascular inflammation. So on those patients, they can die very early. They can die of cardiac involvement very early. And we have to monitor them. We have to detect the early problem. We go for ECG and we detect QT, prolongation, corrected QT dispersion, diastolic dysfunction early, and tissue Doppler that has been introduced recently. We don't wait till the patient dies suddenly. And adequate treatment of hyperglycemia, very strict. Now in the pediatric age group, we go for 3 to 4 injections per day, rapid insulin with every meal. And 2 times per day intermediate insulin, morning and night. Or once per day, long-acting insulin at bedtime. So very strict, because for the pediatric age group, we want them to grow to be old. We want them to come to you. We don't want them to end their lives by 18 years, and that's it. Hypertension and the heart. Does anyone think that hypertension does not affect the heart? Even in the pediatric age group, hypertension affects the heart. And it causes hypertrophy, it causes left ventricular hypertrophy, and we have increased cardiac output and increased systemic vascular resistance that we have to treat promptly. We don't leave them to their fate. Again, dyslipidemias. Dyslipidemias, do we see them in pediatric? I heard this, there was a session about dyslipidemias in the adults, and it's the same. We have to control the low-density lipoproteins very early. When we have an elevated level, we think that it can be secondary to hyperglycemia, to renal disorders, and we search for the cause, and we treat with strict diet, and then strict dietary control, strict hyperglycemia control. And if we do that for 3 months and we still get, there will only be 2 slides.
2 more slides. Carry on. How many slides left? 2 more?
Because I did not start in time. Anyway, so if after 3 months we do not get it controlled, we go further and we go for, as a primary hyperlipidemia, we treat that with a drug that involves lipid-lowering drugs, and then we increase it and make it double drugs, and then we might reach plasmapheresis in very high doses. Of course, hemolytic anemias affect the heart, and sickling affects the heart, and they end up in vaso-occlusive disease or pulmonary hypertension. Thalassemia affects the heart. I didn't know. It was actually a surprise that I found out that thalassemia is also often in India, and that you see them quite a lot. We have published a lot of papers around especially pulmonary hypertension in beta thalassemia cases, but we would not forget myocardial cirrhosis, cardiomyopathy, stroke, arrhythmias, etc. And we have to control those patients by giving adequate, frequent blood transfusion to give the hemoglobin above 10 and prompt iron chelating agents every day by dysphorxamine pump for 8 to 10 hours, hypercoagulable and prothrombotic states. And at last I will talk about chronic lung disease. Also, they cause pulmonary hypertension in the most cases. In malignancies, yes, we have a problem. They present with cardiac prolonged QT or direct invasion, eosinophilic endocarditis. And lastly, I would like to invite you all to visit Egypt, which is as beautiful as India. Thank you.
Thank you.
Thank you very much, Sonia. That was a very beautiful presentation. And I have been to your country, and it is fascinating. 5,000 years of history. No other country has got except India and China. Please come.